7 in the morning. You are standing in your kitchen, holding a small white pill between your fingers. Maybe it says Donepezil on the bottle. Maybe Memantine. Maybe both. You place it on your tongue, wash it down with water, and move on with your day. You have done this every single morning for the past year. And here is the truth nobody has said to your face. You have almost no idea what that pill is doing inside your brain. You do not know how to tell whether it is actually working. You do not know what signs mean it is doing more harm than good. And you were never told at what point continuing the medication may no longer make any medical sense. Right now, millions of Americans over 65 are taking one or both of these drugs. Most were handed a prescription, given a 90-second explanation, and sent home. No one sat them down. No one walked them through what these medications can do, what they absolutely cannot do, which side effects get routinely dismissed as just aging, and when the drug should be stopped entirely. That is exactly what this video is for. The system profits when patients stay passive and uninformed. This channel exists to change that. What you are about to hear is what should have been explained the day that prescription was written. Before we talk about the drugs, you need to understand what they are fighting against. Because without that context, none of the information that follows will make sense. In a healthy brain, neurons communicate by sending chemical signals across tiny gaps called synapses. One of the key messengers in that system is acetylcholine, a neurotransmitter directly involved in memory, learning, and attention. When acetylcholine flows properly, your brain forms memories, retrieves them, and keeps you engaged with the world around you. Alzheimer's disease attacks that system. Two types of abnormal protein deposits begin accumulating in the brain. Between neurons, sticky clusters called amyloid plaques form and disrupt cell-to-cell communication. Inside neurons, twisted fibers called tau tangles destroy the internal transport system that keeps the cell alive. Both processes damage and eventually kill brain cells, particularly in the hippocampus, the region of the brain responsible for forming new memories. That is why short-term memory is almost always the first thing to go. Here is the part most patients and families are never told clearly enough. This process does not begin when symptoms appear. It begins a decade or more before that. By the time someone forgets a name often enough for the family to notice, by the time a doctor writes that first prescription, significant structural damage has already occurred. Neurons have already died. Synapses have already been lost. This is the critical context that shapes everything about how these medications should be understood. They are not entering a healthy battlefield. They are entering a brain that has been under siege for years. And that single fact changes what you should realistically expect from any pill you swallow at 7 in the morning. First, something that causes genuine confusion. Donepezil and Aricept are the same drug. Aricept is the brand name. Donepezil is the generic. I have had patients come to me convinced they were taking two different medications because the pharmacy switched manufacturers and the name on the label changed. They are not two drugs. They are one drug with two names. Now, what does it actually do inside your brain? Remember the acetylcholine we just discussed, the chemical messenger critical for memory and attention. In Alzheimer's, the neurons that produce acetylcholine are dying. Less production means weaker signals between brain cells. Your brain has an enzyme called cholinesterase whose job is to break down acetylcholine after it has delivered its message. In a healthy brain, that cleanup process is normal. In a brain that is already running low on acetylcholine, that enzyme is now destroying a resource you cannot afford to lose. Donepezil blocks that enzyme. Think of it this way. Your brain is a room with a leaking faucet. The faucet produces less and less water every month. Donepezil does not fix the faucet. It plugs the drain so whatever water still drips in stays in the basin a little longer. That is the honest picture. Donepezil does not stop the disease. It does not repair damaged neurons. It does not reverse memory loss. It temporarily amplifies a fading signal in a system that is still declining underneath. For some patients, it slows the visible progression for months, sometimes a year or two. For others, the benefit is minimal or undetectable. Most patients start at 5 milligrams daily, increasing to 10 milligrams after 4 to 6 weeks. A realistic effect, if one appears, typically takes 8 to 12 weeks to notice. And what working looks like is not recovery. It is a slower rate of decline. That distinction matters enormously. Memantine works on an entirely different system, and understanding this matters because many patients take it alongside Donepezil without knowing why they are on two drugs that do two completely different things. Where Donepezil works on acetylcholine, Memantine works on glutamate. In a healthy brain, glutamate is essential. It is the main excitatory neurotransmitter, the chemical signal that fires when you learn something new, form a memory, or concentrate on a task. Normal glutamate signaling is how your brain stays sharp, but in Alzheimer's, damaged and dying neurons begin to leak glutamate continuously. Instead of controlled, purposeful bursts, the surrounding brain cells are now being bombarded with constant stimulation. That overstimulation does not make you think better, it kills neurons faster. In medicine, this process is called excitotoxicity. The very chemical that is supposed to help you learn is now poisoning the cells around it. Memantine partially blocks the receptors that glutamate activates, specifically the NMDA receptors. It reduces the toxic background noise without completely shutting down the normal signals your brain still needs. Think of it as turning down the volume on a speaker that is blasting so loud it is blowing out the other equipment in the room. Memantine is typically prescribed for moderate to severe stages of Alzheimer's, often in combination with Donepezil. The logic is straightforward. Two drugs, two different mechanisms, two separate fronts of the same battle. Clinical evidence shows that the combination can produce a modest additional benefit in daily function and behavior compared to either drug alone. But I need to be direct with you the same way I was about Donepezil. Memantine does not cure Alzheimer's. It does not halt the disease. It manages symptoms and may modestly slow functional decline. That is valuable. But it is not what most families are hoping to hear when they pick up that second prescription. Every medication handout lists nausea and diarrhea. Your pharmacist mentioned those. Your doctor probably mentioned those. What almost nobody tells you about are the side effects that get mistaken for something else entirely. Donepezil can slow your heart rate. The medical term is bradycardia. For a healthy 40-year-old, a slightly slower pulse is meaningless. For a 75-year-old with existing cardiovascular issues, it can cause dizziness, fainting, and falls. A fall at that age is not a minor inconvenience. It is a fractured hip, a hospital stay, and a recovery that some patients never fully complete. And the family never connects it to the pill they gave their mother that morning. Then there are the nightmares. Donepezil increases acetylcholine activity, and acetylcholine is heavily involved in the REM sleep cycle. Many patients on this drug develop vivid, disturbing nightmares and severely disrupted sleep. Caregivers almost always attribute this to the dementia progressing. It does not occur to them that the medication itself is generating the symptom. Loss of appetite follows a similar pattern. The patient eats less, loses weight, becomes frailer. The family assumes the disease is advancing. In many cases, the drug is suppressing their appetite. Urinary incontinence, blamed on age, blamed on the condition, rarely investigated as a pharmacological side effect. But acetylcholine directly stimulates bladder contractions. Increase its activity and you increase urgency. Memantine carries its own disguised problems. Dizziness, confusion, headaches. In a patient who already has dementia, how do you distinguish a drug side effect from disease progression? Most families cannot. Most doctors do not take the time to help them try. This is the insight that changes everything. If your loved one suddenly got worse, the question is not only is the disease advancing, the question is also could the medication be doing this? You just heard something that could genuinely change how you or someone you care about is being treated. That a medication meant to help might be causing the very symptoms the family is watching in fear. Most people hear that, feel the weight of it, and do absolutely nothing. They watch the video, they worry quietly, and they go back to their day. You do not have to be most people. You can actually take a step right now. Care Health is a free platform that connects you with healthcare options, screenings, clinical trials, and new treatments in your area, specifically for what we are discussing today. That includes cognitive health screenings, dementia-related clinical trials, exploring newer approaches, and medication review programs, where a professional evaluates whether your current prescriptions still make sense. You fill in a short form, date of birth, gender, whether you have children under 18. It takes 30 seconds. No cost, no commitment. Care Health simply matches you with relevant options near you. The link is in the description below this video. There is also a QR code on screen right now. Open your phone camera, point it at the code, and tap the link that appears. If you are watching on your phone, tap the channel profile picture to find it. As your doctor, this is what I would tell you to do next. Do not just sit with concern, act on it. Now, back to what you need to know about these medications. because the next part is something most doctors simply do not have time to explain during a 12-minute office visit. This is the question I hear from nearly every family. Is the medication doing anything? And the honest answer is that nobody gave them a clear way to tell. There is no blood test that measures whether Donepezil is working. There is no brain scan that lights up and says Memantine is helping. The assessment is entirely functional and behavioral. It is based on observation, and that observation falls almost entirely on the family because a doctor sees the patient for 12 minutes every few months. You see them every day. Here is what to actually watch for. After starting the medication, is the person more alert, more present, more engaged in conversation than they were before? Are they maintaining daily tasks they had been beginning to lose, getting dressed independently, following a television program, remembering to eat? Has the rate of decline slowed compared to what you were seeing in the months before treatment started? These are the real signals. Not a cure, not a reversal, a slowing. The typical timeline is 8 to 12 weeks before a meaningful difference becomes visible, if one is going to appear at all. Some patients show a noticeable stabilization. Others continue declining at exactly the same rate as before. Both outcomes are real, and both are important information. Here is what most families do not know. You have every right to request a structured medication review. That is a dedicated appointment where the prescribing doctor formally reassesses whether the current drug is still providing benefit, whether the dose should change, or whether it is time to stop. This is not a routine checkup, it is a focused evaluation. Most doctors will not offer it unprompted. You need to ask for it. Write those words down. Structured medication review. Bring them to your next appointment. Nobody wants to have this conversation. Not the family, not the doctor. But it is medically essential, and avoiding it does not protect anyone. It simply delays a decision that the patient's body has already made. Remember the leaking faucet analogy from earlier. Donepezil plugs the drain so whatever acetylcholine your brain still produces stays active a little longer. But the faucet is still closing. There comes a point in the progression of Alzheimer's where the neurons that produce acetylcholine are so depleted that there is almost nothing left to preserve. The drain is plugged, but the faucet has gone dry. At that stage, the drug cannot boost a signal that no longer exists. What remains are the side effects, the slowed heart rate, the nightmares, the appetite suppression, the incontinence. You are now paying the full cost of the medication with none of the benefit. Clinical signs that suggest this conversation is overdue include a sharp, sustained decline in function despite consistent medication use, inability to perform any basic daily tasks independently, loss of meaningful communication, and the emergence of side effects that are visibly reducing quality of life. If the decision is made to stop, it must be done gradually. Donepezil in particular should never be discontinued abruptly. A sudden removal can cause a rapid worsening of symptoms, not because the disease jumped forward overnight, but because the brain loses even the small chemical support it had grown accustomed to. Aricept and crinoworkol. A slow supervised taper under your doctor's guidance is the only safe approach. I need to say this directly to every caregiver listening. Stopping the medication is not giving up. It is not abandoning your loved one. It is recognizing that the goal of care has shifted from slowing decline to protecting comfort, dignity, and quality of life. That shift is not failure. It is the most compassionate medical decision you may ever make. Everything we have discussed so far, Donepezil and Memantine, manages symptoms. Neither drug touches the underlying disease process. Neither removes the amyloid plaques that are destroying brain tissue. For decades, that was all medicine had to offer. That has begun to change. A newer class of drugs has entered the landscape. They are called anti-amyloid monoclonal antibodies, and they work on a fundamentally different principle. Instead of boosting fading chemical signals, these treatments are designed to target and clear the amyloid plaques themselves, the proteins that accumulate between neurons and disrupt communication, the actual physical debris of the disease. These drugs are administered by intravenous infusion, typically every 2 to 4 weeks in a clinical setting. They are not pills you take at home. Qualifying generally requires an early-stage diagnosis with confirmed amyloid presence on a PET scan or in cerebrospinal fluid. That means they are not available to everyone. Now, I need to be completely honest with you because this is not a simple victory story. The clinical benefits observed in trials have been statistically significant but modest. We are talking about a measurable slowing of decline, not a reversal, not a cure. And the side effects are serious. Brain swelling, called ARIA-E, And small brain microbleeds called ARIA-H occur in a meaningful percentage of patients. Regular MRI monitoring is required throughout treatment. The cost runs into tens of thousands of dollars annually. The medical community is genuinely divided on whether the benefits justify the risks and expense for most patients. That debate is ongoing, and it is legitimate on both sides. I am not telling you to pursue these treatments or to avoid them. I am telling you they exist, how they work, and what the real trade-offs are. You deserve that information, so the next time you sit across from a neurologist, you can ask informed questions instead of simply nodding. There is a conversation that almost never happens in a neurology office. The doctor writes the prescription, explains the dosage, and the appointment is over. What is rarely discussed with the same seriousness is what you can do outside of medication that has measurable, documented effects on how quickly your brain declines. These are not soft wellness suggestions. These are evidence-based interventions supported by large-scale longitudinal research. First, cardiovascular fitness. Your brain consumes 20% of your body's oxygen supply. Every drop of that oxygen arrives through your blood vessels. When you walk consistently, when your heart works efficiently, cerebral blood flow increases. Neurons receive more fuel. Multiple studies show that regular moderate exercise, even walking 30 minutes most days, is associated with significantly slower rates of cognitive decline. Second, blood sugar control. Insulin resistance is not just a diabetes problem. Research has established a direct link between chronic elevated blood sugar and accelerated Alzheimer's pathology. Glucose damages the small blood vessels feeding your brain and promotes the very inflammation that drives plaque formation. Some researchers have called Alzheimer's type 3 diabetes. That is how tight the connection is. Third, sleep. During deep sleep, your brain activates what is called the glymphatic system, a waste clearance network that flushes out metabolic byproducts, including amyloid. Disrupt that process chronically, and the waste accumulates faster than your brain can remove it. 7 to 8 hours of quality sleep is not a luxury. It is neurological maintenance. Fourth, social engagement and cognitive stimulation. Brains that are actively challenged through conversation, problem-solving, learning, and meaningful human interaction build what neuroscientists call cognitive reserve. That reserve does not prevent the disease, but it extends the period during which the brain compensates for damage. For anyone already on Donepezil or Memantine, these interventions work alongside the medication. They are not replacements. They are force multipliers. Here is exactly what to do with everything you just heard. Not someday. Not when things get worse. Now. 1. Review the current medication list. Sit down with every bottle on the counter and confirm you understand what each drug is, what it does, and why it was prescribed. If Donepezil and Aricept are both on the list, you now know that is the same drug. If you cannot clearly explain why each medication is there, that is a gap your doctor needs to fill. 2. Schedule a dedicated medication review appointment, not a routine visit where the doctor checks blood pressure and renews prescriptions in 10 minutes. A focused conversation specifically about whether the current regimen is still appropriate, whether the dose should change, and whether any symptoms you are seeing could be side effects rather than disease progression. You have to ask for this. It will not be offered. 3. Start a simple written log today. Alertness, mood, appetite, sleep quality, bathroom habits, ability to complete daily tasks. 1 or 2 lines each evening. Bring that log to the next appointment. Doctors make better decisions when families bring objective data instead of a general feeling that things seem worse. 4. Ask the prescribing doctor this exact question. At what point would you recommend we reconsider this medication? Get that answer while the conversation is still calm and clinical, not during a crisis. 5. Have the conversation about advanced care preferences now, not next year. Not when it becomes urgent, while your loved one can still participate in decisions about their own care. What matters to them? What quality of life means to them? That conversation becomes impossible if you wait too long, and the guilt of not having had it follows families for years. How old are you? Write it in the comments. I want to know which age group is watching, because it directly shapes what I cover next on this channel. These medications have a role. Donepezil and Memantine can provide real, measurable benefit for the right patient at the right stage. That is not in question. What is in question is whether you understand that role clearly enough to make informed decisions. What these drugs can do, what they cannot do, what side effects to watch for that no one warned you about. And when continuing the prescription stops helping and starts costing your loved one comfort and quality of life for no return. The difference between passive treatment and informed care is not medical training, it is information. The kind of information that should have been given to you the day that first prescription was written. Nobody at a 12-minute office visit is going to sit you down and walk through the pharmacology, the realistic expectations, the side effect traps, and the difficult conversation about when to stop. There is no billing code for that. There is no revenue in it. That is exactly why this channel exists. And remember, that free health screening link is in the description. 30 seconds could connect you with cognitive health screenings, clinical trials, and medication review options you did not know existed. Take care of yourself.